our group tonight for this CME event sponsored by our Center for Gastrointestinal Cancers here at Smilow Cancer Hospital and Yale New Haven Hospital and Yale School of Medicine. So we're delighted that you took some time out from, I know it is a busy time of year for many, to join us this evening. We're going to be focusing in on gastroesophageal cancers. We have 3 talks tonight. We'll give about 30 minutes to each with some time in each session for some questions. And we'll try to leave some time at the end for questions as well. In terms of the order of the talks, we're going to start with Dr. Boffa, then move on to Dr. Robert, and then myself. I am Dr. Lacy by way of introduction, and I will introduce myself again at the end. So we're going to, without further ado, get started. And Dr. Boffa is going to kick this off this evening. Dr. Boffa is a colleague that I work with very closely. He is professor and chief of the Division of Thoracic Surgery here at the Yale School of Medicine and Cancer Center. And he is going to be speaking to us tonight about the impact of recent trials on systemic therapy before and after esophagectomy.
Thank you very much. And again, thank you to everybody who is joining either live or after the fact. I will tell you that I'm a fast talker and I always give short talks. So if you feel like you did not get your money's worth, I don't know what to tell you. But I will, my email is daniel.boffa@yale.edu. And if there's anything I say that is unclear or you want to talk more about, please don't hesitate to reach out to me. So I have a couple of disclosures. I'm going to talk first about preoperative therapy, and then I will talk about postoperative therapy in patients that have what is perceived to be resectable esophagogastric cancer. So there was a study, the CLGB 80803 trial, that was PET guided therapy in the preoperative setting in terms of which chemo radiation cocktail to be administered. This is a really interesting study, in my opinion. I was fortunate enough to be involved in this. I think it's understanding a little bit of the background. I think it was a cleverly designed study. I don't know that it was a hugely impactful study, but I think the study design was pretty interesting. So the fundamental principle that this was based on is that if you give induction chemotherapy and radiation, about 25% of people will sterilize the cancer within the surgically removed specimen. But that means that 3 out of 4 patients actually have some form of resistance to that neoadjuvant treatment. And we know that the best prognosis is in patients who have a pathologic complete response. And so it doesn't take much to connect those dots that if we can increase the path CR rate, that there's a potential that we can make people live longer. And different chemotherapies have been used for esophageal and gastric carcinoma. And there is potentially a different mechanism of resistance. And so just because somebody's resistant to one may not mean they're resistant to both. So the question is, what if you changed chemotherapy? If there was a way to know it wasn't working, could you change it during the neoadjuvant course to something that's more effective? So these are the 2 common regimens, carboplatin paclitaxel and oxaliplatin and 5-FU. And so they actually do both have platinum backbones, but they do have different mechanisms of resistance. And so this is sort of the founding principle that if you give a chemotherapy regimen, we're just going to call regimen A, and you assess mid-treatment PET, and if they don't reduce the max SUV by 35%, so go from 10 to 6.5, if they don't have at least that much of a response, and you keep going with the same regimen, then the chance of you having a pathologic complete response is quite low. Sorry, 1 second here. I seem to have, there we go. It's only 5%. However, if you are giving one regimen and you notice that there's no PET response, but change to a different chemotherapy regimen for the chemoradiation phase, the null hypothesis is that we can take this 5% path CR rate and bump it up to 20%. So that was the foundation for the CLGB study. And so this was in adenocarcinoma patients. It was a phase 2 trial. They had to at least be clinical stage T2 or have lymph node metastases. Now, one thing that's just really important is you could get into this trial being a T2 and 0. That was the minority of the patients. And I would say this study was not powered to look at that subgroup. So just because a group is in a trial does not mean the trial findings universally apply to every small subgroup. I think that's important. And that's, I think, been misinterpreted. And the patients had to have a distal esophageal or GE junction cancer. And again, as I mentioned, they would get chemo. There would be an early PET assessment. And if they had a response, you would keep going. If you didn't, you would change to another form of chemoradiation and then have an esophagectomy. And about 3/4 of the patients in both arms went on to have an esophagectomy. So there certainly was some fallout between induction and moving on to esophagectomy. And again, the primary endpoint of this study was path CR in the patients who were deemed non-responders. So again, that's that group we thought would have a 5% path CR rate. And so could we bump that up by changing the chemotherapy? So green is starting with FOLFOX, but responding and continuing with FOLFOX. The yellow is starting with FOLFOX, but then changing to carboplatin paclitaxel. Blue is starting with carbotaxol. And if you continue in blue, then you are a responder. If you did not respond, then you change to FOLFOX. So if you look at the path CR rate in the responders, there's a pretty big difference. So of the people that got FOLFOX, these are adenocarcinomas. If you started with FOLFOX and you responded, and that was 73 out of 129 were responders, and you kept going, the path CR rate was 40%. So that's pretty good. So that's higher than that 25% historical number. If you started with carboplatin paclitaxel and you responded and kept going with carbotaxol, your path CR rate was 14%. That's pretty darn low. And I'm going to give you some context in terms of other recent trials. Now, the non-responders. Now, this is the group we were trying to bump up from 5%. So if you started green, if you started FOLFOX, you were deemed a non-responder and changed, the path CR rate was 18%. So that's pretty darn close to 20%. And however, if you were a non-responder to carboplatin paclitaxel and you switched, you actually got 20%. So this was actually, this actually met criteria for both arms. So this was actually a positive study, again, because we were expecting a 5% path CR rate from historical data, and both of these were significantly higher than what we would have anticipated. So just some stats from CLGB 80803. The complete resection rate, so granted, 3 out of 4 patients that started in each arm went on to get an esophagectomy. The path CR, the complete resection rate was 94%. That's pretty good. That's pretty average. The mortality rate, this is the 90-day mortality rate, is 3.3%. That's quite low. So in the French and German trials, they had double-digit 30-day mortality. So this is quite low. Usually the 90-day mortality is twice the 30-day mortality. And so this is quite low. 5 of 6 started with carboplatin paclitaxel. So I think that's just a statistical, I think that's just an aberration, but maybe a light signal. And the 5-year survival for this study was about 45%. So if you look at the difference between responders and non-responders, so again, how did people do based on whether they respond to that early PET? The responders, as you might think, would have had a better outcome, 49% 5-year survival versus 39%, and the median survival was almost twice as long. Now, if you look at the different treatment groups, so the red is FOLFOX, the dash is responder, the solid line is the non-responder. So you can see those are wider than the blue lines, which are the people that started with carboplatin paclitaxel. So here's how I put this study together. So that the path CR was more likely if you started with FOLFOX. Of all the patients that started with FOLFOX, they were more likely to have a path CR. So when you combine and average this out, 31% versus 14% in the carboplatin paclitaxel group. Now, this is a bit odd because, in the cross trial, which was carboplatin paclitaxel, all the way through, the path CR rate was 29%. So something's funny in that 14%. So it's hard to know what to make of that, but at least in this study, there was a difference based on whether you started with FOLFOX or carboplatin paclitaxel. But path CR does not tell the story, because when you actually look at the overall survival, this is the 5-year overall survival. The mustard and there's probably a fancy name for that color, maybe I forget what you call that color, but brownish yellow. They're both around 41, 42%. And if you look at the greens, the FOLFOX patients, they're all in the same ballpark. So I don't think, if anything, we were expecting this carboplatin group, which went all the way through without a PAT CR of 14%, they still had a 44% 5-year survival. So path CR definitely does not tell the whole story. Now, the other question is, this study, the biggest part of this study was a pivot, meaning if you use a PET to change what you're going to give people, does that help? So these were two common chemotherapy regimens used with radiation, that there was a pivot in place. So with this pivot, did we make anything better? So overall, the 5-year survival in this study was about 45%. So the pivot gets you about 45%. However, the cross trial, it's pretty much the same. And that was carboplatin and paclitaxel all the way through. So it's hard for me to say that using PET to guide your therapy, at least in this context, that it really changed the overall survival. Now, that doesn't mean that there's never a role for this, but it does mean pivoting between these two regimens, carboplatin and paclitaxel and FOLFOX, trying to mimic this and thinking you're going to make people live longer. I think that's a hard sell. So what are the take-home messages? That the PET does predict resistance. So I think that of the non-responders in general, they had lower response rates. So if there was a better pivot potentially, there is potential for early PET response to predict overall response to chemoradiation. I think that this adds to a signal. Now, again, this is a very soft call, and Jill, I'd love to get your feedback on this, but I think this adds to a signal that if you have a squamous cell carcinoma, that really carboplatin and paclitaxel makes the most sense. And so this is the cross study. And again, I'm just saying it adds to a signal. I'm not saying that this is an absolute, but this is the squamous cell that got chemoradiation and squamous cell that got surgery only. And you could see how wide apart those bars are. The lighter gray bars, those are the adenocarcinoma with and without induction therapy. So I think this is pretty impressive that with squamous cell, the induction carboplatin and paclitaxel really does have a profound widening. I think this adds to a signal that FOLFOX is better with adeno that compared to carboplatin paclitaxel. There are studies like Protect 1402 that are going to compare different induction regimens, but I think this adds to that signal. So why do I say that? So if you look at the FOLFOX, the people that started with FOLFOX, the lines are just more separated based on response. And so I think it does a better job stratifying people that are going to respond and not respond. So again, that's not telling you prognostically. It's just saying if the whole point of this study is to be able to separate responders and non-responders, it's the PET format seems to be better with FOLFOX. The blue lines are people that started with carboplatin and paclitaxel. This is the CROSS study. And if you, this is the FOREST, which basically looks at unplanned, these are unplanned subset analyses from the CROSS study. This is old now, but if you actually look at by the histology, and to be clear, the majority of these patients were adenocarcinoma patients, it actually was not statistically significant in the adeno group. Clearly, the mortality reduction was less impressive in adeno versus squamous cell. So again, I'm not saying it's wrong to give carboplatin and paclitaxel to adeno, but I do believe the CLGB study adds to a signal that in adeno, FOLFOX is actually a better way to go. So now I'm going to pivot to postoperative therapy, and I'm going to talk just briefly about Checkmates 577. And this was giving nivolumab after completely resected, so they had negative margins, esophageal cancer that had some residual disease. They were not anybody that was anything other than a pathologic complete responder. So they accrued between 16 and 19, a lot of different centers. They had to be clinical stage 2 or 3. They received induction chemoradiation with 2 common backbones of chemo that was platinum based. They had to have a complete resection, no positive margins, and then they were randomized whether or not to start between 1 and 4 months after the complete resection. And again, they had to have some residual disease in the pathologic specimen. So it could not be a complete pathologic response. And so it was nivolumab for 4 months that was given every 2 weeks, and then it became monthly after that. And it continued either to progression, or if it was terminated for toxicity, or patients got to a year. And again, this was designed for disease-free survival. And so this just highlights where the patients came from. About 40% were from Europe, 60% were esophageal, and 40% were gastroesophageal junction. 71% were adenocarcinoma. Now, the PD-L1 count, so was about 16% were PD-L1 positive. Now, that's different, something Dr. Robert is going to talk about, which is a complete positive score, a composite positive score, which is a different. And just to be clear, in a post hoc analysis, that score was positive, and about 57% had 5 or more percent cells positive. So this looks like there was very little PD-L1, but actually, when you use the composite score, it's actually was higher. This was well tolerated. So there were no grade 5 adverse events. About a third of patients had any 3 or 4 adverse events. It was actually pretty similar between the placebo and the nivolumab arm. Discontinued treatment was 9% in the nivolumab and 3% in the placebo group. Sorry. So when we look at disease-free survival, the blue line is the nivolumab arm and the red line is placebo. So you can see there was a really significant difference in the disease-free survival. If you look at the median disease-free survival in the nivolumab group, it was basically twice that of the placebo group. When you look by histology, so the blue lines are the patients who got nivolumab. The red lines are the placebo groups. And when you actually just break it down by histology, so if you look at adenocarcinoma, the median disease-free survival was 19 versus 11 months. And when you look at squamous, it was actually 29, almost 30 months versus 11 months, which is something we've seen before, where there seems to be a little bit more activity in the squamous cell patients. And again, 70% of the patients in this study were actually adeno. When you look at the forest plot, again, these are all unplanned subset analyses. When you look at adeno versus squame, they were both significant. Adeno was flirting with non-significance, but was significant. When you look at PD-L1, so the people that had PD-L1 less than 1, now granted, this is probably just a power analysis, but the people with PD-L1 less than 1, it was significant, but they had 600 patients versus the patients who were greater than 1, and these are tumor cell PD-L1. It actually was not significant. That doesn't necessarily make sense, but I think it's got to be a power issue. And interestingly, if you, the people who had node positive pathologic specimens, they seem to do a little bit better and have a bigger impact. The people that were node negative, actually, it did not reach significance. And again, these are unplanned subset analyses. So I don't think these should be practice changing, but should inspire future deliberation and future trials. And if you were really on the fence as to should somebody get immunotherapy, if they were in a group where there really wasn't significance, I think that's one perspective to consider. Older patients, we've seen this before in different immunotherapy adjuvant trials. It was not significant, although it was a hazard ratio less than 1. And this very well may have been a power issue. But again, if you had an older patient and you were on the fence, I think you can consider that the impact might be less. And if you're HER2 positive, this was a very small group. There were only 63 patients. So I don't know how much stock to put into this, but just something to think about. So there are there's a bunch of ongoing studies. These are a couple interesting ones, which is FLOT versus cisplatin 5-FU, and in patients that have resectable gastric and GE junction cancer, getting adjuvant Pembro versus placebo, and then Keynote 975, which is for either people who have unresectable disease or don't want esophagectomy, which I don't know why anybody wouldn't want an esophagectomy, giving definitive chemoradiation, again, with one of the common backbones, and then Pembro or not. So a lot of information. I appreciate your time. So this was a chemotherapy talk by a non-chemotherapyologist. So take it for what it's worth. But again, thank you for your attention.
Dan, thank you. That was great. Really nice review of some very, very important studies, one of which is clearly practice changing, adjuvant Nivo, a huge advance in the field, an advance that we've been waiting for I think a couple of decades. So really exciting to have the adjuvant therapy option with nivolumab in these patients. We are happy to take questions in this format. It's in the chat box, so please put any questions in that you may have. Dan, if I may, I have a couple of for you. So the CLGB study left us hanging with a lot of unanswered questions, and a wish list for maybe how they had designed the study. But just your opinion on the question of induction chemo versus prior to chemoradiotherapy. There's been no study that's compared adding induction chemo prior to chemoradiotherapy versus just chemoradiotherapy followed by esophagectomy. It's from a pragmatic perspective, we find it useful to start with induction chemo because often dysphagia resolves rapidly. So we do it pretty routinely. And I think based on the study you reviewed, we have shifted towards FOLFOX in the adenocarcinomas. Do you have an opinion? I will just ask for your opinion on whether you think induction chemotherapy is important. The survival statistics from that study were impressive. I think better than prior studies. Could that in part be due to the induction, the inclusion of induction chemo, or do you think it just has more to do with maybe FOLFOX in the adenocarcinoma subset?
Yeah, so the fact that there were that roughly a quarter of patients did not get an esophagectomy could be that anytime there's attrition, that could be appropriate patient selection. Patients progress and they avoided a surgery that didn't help them. I think in my experience, there are definitely patients who achieved a superior nutritional status and they were better surgical candidates ultimately because they got induction chemo and then moved on to chemoradiation instead of just getting hammered right away. Clearly. I've also had patients that got so much chemo, by the time they got to the operating room, they just sort of never recovered, and it increased their risk. And so one thing I love about Connecticut, I've practiced in a couple of different places. The medical oncologists have been really engaged and just say, and been really open to this conversation. And often, there's no scientific way of doing this, but a gestalt of what's the regimen that's going to really get them to take advantage of all modalities? And so I do think if they're obstructive and nutrition's an issue, trying to optimize them, I think in our experience, the induction chemo is very effective. But I do think there are people who just get so debilitated from all of the induction, and try to identify those people so that they don't miss out on an opportunity of a curative and resection.
Great.
I have a question before we let Dan go. I don't know how close to this part of the data you might be, but in the trial with nivolumab, did anyone have to withdraw due to immune-related adverse events from the checkpoint? Or was there any incidents, or could you talk about that at all?
Well, that's a great question. And Jill is going to know exactly what I'm talking about here, but so in the trial, discontinuation of therapy was about 10%, 9-10%. And I would say, I think that is an overly optimistic number. We've now had the advantage of seeing people on nivolumab after esophagectomy, and I don't think it's a walk in the park. I think it's tolerated, but I think it does, unlike, because I do a lot of lung cancer and we give a ton of immunotherapy. I personally think it is a real thing to go through immunotherapy after esophagectomy. And I would guess that more than 10% of people have a hard time with it. But Jill, what is your sense of that?
Well, I think this is a learning curve for all of us because this is very new. So I think we don't have vast experience yet. In that study, I think it was about 10% discontinuation for treatment-related AEs, and I would imagine that most of those were felt to be immune-related. So, I think in general, we think Nivo is a well-tolerated drug, a single agent with a low incidence of serious immune-related AEs. But I think you're right, Dan, this is a new patient population. We've not done this before in large numbers. So I think to be continued, we'll have to see how it plays out. Just one final question, and maybe this is the lead in for Marie's talk. You showed some of the information about PD-L1 scoring in this study. Was that done in the post-treatment pathologic specimens, Dan? Do you know off the top of your head?
Yeah, that's a great question. I
Okay.
don't know.
Because, you know,
Yeah.
Marie's gonna I think, educate us all about some of the challenges with PD-L1, but I think one issue is that we don't really have, I don't think, a clear understanding of what we would see with PD-L1 scoring pre-treatment and then post-chemoradiotherapy, but you have to imagine it's going to affect the results. So, all right, Dan, thank you very much. That was really a great review of really important studies. So we're going to move on to our second talk. We're going to shift directions now and take a very deep dive into immunotherapy. And as I think most of you know, in the last 2 years, we have heard a lot about immunotherapy in gastroesophageal cancers, and we are deploying it quite regularly now in the first line setting. And there's a lot of chatter about how do we use PD-L1 as a predictive biomarker in choosing in patients for immunotherapy in the first line setting and beyond. And Marie is going to shed some light on that very confusing topic. And then with that backdrop, then I will then review some of the more recent studies. So Marie, Dr. Robert, another wonderful colleague of mine that I get to work with on a regular basis, is professor of pathology, medicine, and human and translational immunology here. And she directs our GI pathology program. And very importantly, and relevant to her topic tonight, she is co-leading an important international study on inter-observer agreement in PD-L1 CPS scoring in gastric cancer. So Marie, thank you.
Thank you so much, Jill. And I'm still smiling despite being on doing that study. Okay, so I think you can see my screen. Well, I'm delighted to be here with you today in person and those watching later on. And I want to thank Dr. Lacy for the invitation and Dr. Boffa for sharing the virtual podium this evening. I hope that I will only spend about 20, maximum 25 minutes discussing really the inside baseball, nitty gritty, in the weeds. What does it mean to score a PD-L1 immunohistochemical stain in gastric cancer? And this would apply to other tumors as well. And so the subtitle is The Challenges in Interpretation and How, for a clinician, how should one decipher the reports? These are my disclosures. So by way of outline, I'm just going to spend a moment, just a second, on things you already know way better than me: the rationale for blocking PD-1 receptors on immune cells in cancer. Spend the bulk of the time talking about an overview of the development of the PD-L1 immunohistochemical stain as a companion or complementary diagnostic for the use of checkpoint inhibitors. And we're really going to look very, very intensely at how PD-L1 stains are interpreted at the microscope. And I will show you examples and ask you to do this with me. And in doing so, I hope to sort of unveil the challenges in applying the scoring criteria that are recommended by the Agilent DACO group for tumor proportion score, what we're really about today, the combined positive score, and all of that is about scoring tumor cells and immune cells. And this will get to the question of inter-observer agreement and reproducibility of results. Finally, I'll hope to help decipher reports, at least the Yale reports, and touch on what I think would be, I think what everyone thinks who does this for a living is what would be great future directions. So this is the tried and true example. There's a cartoon, there are many. This happens to be photos from the Agilent DACO training manual for pathologists. Just to remind everyone, what are we staining here? What are we talking about? So PD-L1 and also PD-L2 stand for program cell death ligand. So the ligand is the thing sticking out of the cell on the membrane. And it's expressed normally in normal cells, normal immune cells, epithelial cells, fibroblasts, and endothelial cells. And the ligand, the receptor for this, or the PD-1, which is the programmed cell death receptor, is expressed on the surface of inflammatory cells, CD4 positive and CD8 positive T cells, natural killer cells, B cells, macrophages, and dendritic cells. And in health, the purpose of the PD-L1 ligand is to bind to a T cell receptor and tell it, I'm okay. This is me. This is you. Stop and cease and desist, friend. And this prevents autoimmunity. Interesting when that breaks down, not just because of drugs, but from other diseases, then you can get bad autoimmunity. It is one of the mechanisms, actually, as a side point, is there's a CTLA-4 deficiency that can lead to severe colitis, for example. But in tumor growth, some tumor cells develop the ability and mimic normal cells by upregulating PD-L1 ligand on their membranes. And then they trick the cytotoxic T cell, which binds via the PD-1 receptor. And it inactivates the cytotoxic T cell, which is supposed to recognize this as something that doesn't belong and kill it. And so you all know this very, very well. And therefore, the rationale behind anti-PD-1 therapy is to give an antibody that will bind instead of the PD-L1 ligand on a tumor cell, will block these receptors and allow these cells to then not to say, hey, you're not me, you're not self, and attack. That's the rationale. So, trying to put my picture somewhere. This led to the discoveries about this, the wonderful science, a lot of which done at Yale, led to the development of immunohistochemical PD-L1 stain as a companion, or companion meaning companion diagnostic means if you don't have this result, you can't give the drug, or complementary. We want to know the result, but either way, we'll still use the drug diagnostic. So immunohistochemical stains, if you don't know, they're very, I think you all do. These are a series of antibodies linked together to identify a molecule on a formalin fixed, or it could be frozen, fixed piece of human tissue or any tissue that is mostly in this setting, formalin fixed and paraffin embedded and cut onto a slide. And this is of course, on the manual, they show beautiful stains. This is an example of a PD-L1 stain on a cancer. And you see the brown is positive stain, and it's outlining the cell membrane. So it's membranous, strong membranous staining. If anyone looks at HER2 immunostains, it's very similar. When it's this strong, it's similar to what a 3+ positive HER2 stain would look like. Strong membranous staining on tumor cells. Okay, but that's the manual, and then there's real life. But this development was very successful and led to, in 2015, the DACO, which was bought by Agilent a few years later, PharmDx anti-PD-L1 22C3 assay, which was first developed and FDA approved for lung cancer. In 2017, the combined positive score, I'll be defining all of this, was FDA approved for gastric and GEJ adenocarcinoma after phase 2 Keynote-59 trial. So Agilent or DACO developed, but this approval was based on pathologists at Merck, and I'll talk about this in a moment. The scoring, the putting together of combined positive score, what was it, how to do it, was done in the confines of a single company, Merck. And the FDA approved their methodology. That's how that got going. That's how CPS came to be as a requirement. Was not tested outside of that. It's important to know that. So, but nonetheless, Agilent then developed training modules for workaday pathologists like myself and others to train and learn how to look at PD-L1 stains and produce these scores from the methods developed in-house at Merck. I will just mention that now there are multiple antibodies. I purposefully mentioned the specific antibody 22C3 because that's the one that was approved by the FDA for this purpose and with CPS score and also TPS in lung. There are multiple antibodies available, and at Yale we use the E1L3N antibody that has been shown to have homology and to work equally well as 22C3. And there's also 28.8, SP142. Many proof of concept studies, since I was not involved in those, I feel I can brag for my colleagues, were actually performed by Yale Smilo and Pathology Department faculty. And so it's a nice legacy of progress. But I think it's important is those of us who look at this stain on a daily basis have come to, I would say, almost universally across the United States in any case, and opinions are slightly different in Europe from the pathologists with whom I interact with, that we are having trouble with reproducibility and with, frankly, performing the stain as it is laid out in the guidelines. And I just like to share this with you. We do it. We do our very best. We follow the guidelines, but I would like you to know about some concerns about relying on this immunostain, because I think we can move on, hopefully in the not so far future, to something else. So it starts back from 2017 at ASCO, this presentation by Merck about the development of the combined positive score for the evaluation of PD-L1 in solid tumors using this antibody. And what they discuss is that they had an inter-observer agreement amongst their pathologists of 88%, which sounds pretty good. Further, for a cutoff of CPS score of 1, about 57% of the gastric cancers in their hands had a positive score. I've seen in the literature, and I would say in our hands, it's somewhere more between 30 and 50%, but that's what they found. So that's interesting that in their hands, they got an 88% agreement at a cutoff of 1. But what there are a few questions that this raises once we get into start doing this, as we've been doing for some years now. There's not much data on agreement at other cutoffs, nor at what if the case will come, which it may be coming, that oncologists would like to have an exact value, not a cutoff, not greater than 1, greater than 5, greater than 10, but was it 8 or 45? And I've heard, I'm in discussions now with GI oncology here at Yale about what we should be providing. And this is because the indications keep changing and there's new protocols and wonderful opportunities for patients to be treated with these medicines that may or may not depend upon certain criteria of CPS. And I'm just very curious, I think we have the answer, and we asked this question: how does agreement on combined positive score differ from agreement on tumor proportion score, which is simply the percent of positive tumor cells over the total number of tumor cells, simple straight percentage? And the hint is, you're not surprised by this, you already know, is that pathologists agree much better on TPS if you have 10 pathologists look at the same sample than they would on CPS. We're going to go into why. But the other concepts to put out here is when one puts out in an abstract that, hey, this works and there's great inter-observer agreement. Well, what was your training methodology in this specific setting? And what is the training methodology in the rest of the world in practicing medicine? In fact, the methodology is voluntary. The rigor varies widely. There's no requirement that it's not registered with the FDA that we've done our training or not. This is honor system. So we've all done it. All the GI pathologists at Yale have gone through the training, but there's no requirement that you repeat it every year. What about drift over time after training? So there's a lot of questions. And the unfortunate fact that we seem to notice is that many samples hover near the cutoff. So when it's negative, we're all in agreement. When it's wildly positive and clearly, 10, 20, et cetera score, that's easy because you're way above any cutoff. But we do have many samples that hover near a CPS cutoff of 1. And I know new cutoffs of 5 are coming. I'm just going to highlight here, this is the manual that we use, and I'm going to show some figures and language from this, from the Agilent DACO. This is what we read, and it's a gorgeous picture of PD-L1 staining, it's pristine. And I'm also going to use material from a book written by friends of mine, Sunil Badvi and George Kumar, Predictive Biomarkers in Oncology, and this is an excellent treatise of the topic. This is not to get into the test tube and pipette phase of things, but it is important that we all remember that in any test that's done in a laboratory, there's a quality assurance aspect. And this is, in Kumar's book, they talk about the predictive biomarker quality assurance cycle. And I think it's important to know that when you're taking a sample from a patient, usually in this setting, it's an endoscopic mucosal biopsy that undergoes tissue processing first in formalin and through a series of solutions in the regular histology laboratory that have to be controlled. It's put into paraffin, cut into sections, and then that's the tissue processing, the pre-analytic phase. Then there's a staining, the analytic phase there has to be QC and quality assurance of both the controls and the test tissue sample. And then there's post-analytic. That's the interpretation, scoring, and reporting. So what kind of QC can we really apply? And that's a question to pose yourself when I take you through this. All of this leads to, no matter what, a decision for a patient. So think about, compare this, if you will, as I go through what goes into this, the result of a CPS score, for example, compared to a chemistry test, a blood test in the lab, and what kinds of decisions might be made and how that's done. I won't walk through all this slide, but just to say, those people who do just know that at the back of a test like this one, and hopefully every other one, is a whole, are people who understand what needs to go into the pre-analytic, analytic, and post-analytic quality checks, such that there are things that would, indicators of unacceptable results that would cause us to pause and not report that and start over. I just want to highlight one here, quality of tissue morphology. So the tissue morphology in a biopsy is sort of decided by things that are out of our hands. There's sample, how much tumor is in it versus normal, benign, or in situ. Crush artifact from the biopsy forceps, necrosis, thermal injury, if cautery was used in obtaining the specimen. So we have no control over this, and we try very hard not to ask folks to go back and get more samples and put patients through procedures. We deal with what we have by and large and do the best we can, but it's something to know about. So these are some statements from the Agilent manual, and this is the most important equation that we are living by for gastric and GEJ cancer. So what is a combined positive score? It is, as you know, the number of PD-L1 staining tumor cells, lymphocytes, and macrophages divided by the total number of viable tumor cells. And then we multiply that times 100. So you can see that we ought to be, it shouldn't be too hard to get to something greater than 1 because we're multiplying by 100. So they want us to get to 1. So let's take some definitions now for PD-L1 scoring. Tumor cell. Okay, well, what is that? Well, it sounds pretty obvious, but there are some caveats. Not in situ, not dysplasia or carcinoma in situ. And in esophageal cancer or gastric cancer coming from a background, there's often a dysplastic background on top in the superficial mucosa. That is not to be counted, and that is to be distinguished from the invasive cells coming right off of that in situ component. That's very challenging at times. Areas of necrosis are to be avoided, and one must have a minimum of 100 viable tumor cells in the sample to perform the stain. What is an immune cell? Well, for the purposes of this, for CPS, it consists only of lymphocytes and macrophages. Plasma cells and neutrophils are not to be counted. Those are very common cells in the mucosa, especially plasma cells. Fibroblasts and endothelial cells, which are not inflammatory cells, but are other stromal cells, are not to be counted. All of these things can pick up stain. All of them can pick up a PD-L1 stain, can be positive. So we already said what tumor proportion of CPS is. I want to just point that outside of the GE junction and gastric cancer, in the GI tract, we're doing PD-L1 on many things. And there, because CPS or TPS have not been codified, we report simply the percent immune cells and percent tumor cell staining. And we'll talk about that when we get to reports. Okay, fine. So those are our marching orders. How do we do it? Well, the minimum of 100 cells. We look at various magnifications. This is important. If the specimen includes more than one biopsy in the jar, which it always does, and we put all that on one slide, all the tissue on the slide needs to be evaluated to generate a single CPS score. And if we're doing it on a resection, every single tumor cell, every immune cell should be evaluated. And that's when in tumor. We have a lot of a little table of do's and don'ts, include and don't include, in the numerator and denominator for immune cells. And specifically, what are we grading? Well, for tumor cells, we're looking at membranous staining only, not cytoplasmic. And we are to count a cell as positive if it has any partial or complete linear membrane staining. So half the cell or the whole cell, any part of the cell, any membranous staining of greater than 1+ intensity. So what's interesting is that this is not defined. This is a completely subjective 1+, 2+, 3+, partial, complete. And for the immune cell, lymphocyte or macrophage, membranous staining and cytoplasmic staining count. Again, with basically any amount of staining, you're to count that cell. So let's go through now and see how to do this with some real world samples. Here's a set of biopsies all in one jar. 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12-ish biopsy fragments of various sizes. I can tell at this magnification that they basically all have tumor in them. It's a very generous endoscopist. So we're meant to do an immunostain and count every single one of these pieces. So let's see how that's done. This is one piece at a slightly higher magnification. The bigger poofy cells are tumor cells. The small purple dots are inflammatory cells. Here it is at higher magnification. These are tumor cells, the bigger cells, they're bigger nuclei, a little bit paler. And the smaller purple dots are immune cells. So I just want you to know, the oncologist watching, there is no ocular micrometer or software to do this counting. We are literally at a microscope with maybe an arrow, basically estimating the numbers of denominator, how many tumor cells are here. So that is what I want to communicate to you about the precision. How do we do this? Some people do a gestalt. I do a counting guesstimate, and on the training, in the online training with a guide, someone teaching us how to train at Agilent at DACO, that's as good as they had to offer. That's what we are meant to do. So I will count off 100 cells by hand, 1, 2, 3, 4, 5 at the microscope with the fellow, count 100, and then I do this. I don't want to scare you, but that's what we do. 200, 300, 400, 500, 600. Literally, this is what we have to work with. There is nothing better. Then when we put side by side, as I've done here, the tumor cells, a high power view of the tumor cells with some immune cells, I would just like to point out that some of these immune cells are plasma cells, and we're not to count plasma cells, only lymphocytes and macrophages. The macrophages are always quite hard to recognize and distinguish from a fibroblast or endothelial cell. This is the PD-L1 stain in this example. So we get a sense, here's a membranous staining, probably a tumor cell, so that's one. There are some other cells with some membrane, and I'm not sure what this one is, but chances are it's meant to be counted. That's 2. And we're getting into some things here that have a lot of stain that's very dark, where it's hard to distinguish what cell type it is and how many cells are here. So this is what is challenging when you get big clumps like this. There's a lot of staining here. Here's that same vessel. It's stuff here. It's probably immune cells, and some of them are lymphocytes, some are not. So we do the best we can. In this example, there's some pretty, honeycomb, pretty clear-cut membranous tumor staining, and we could certainly get to cutoffs. We're helped a lot by the fact that we are only, for the most part, giving a cutoff of less than or greater than 1, not an exact number. So one can guess that this degree of staining, and then you're timing that by 100, the equation, we're going to get to greater than 1. So I think this saves us. But if we're going to get to cutoffs of 5, 10, and exact numbers, it's different. In this example, the tumor cells are here, and this very nice example, because these are all lymphocytes morphologically. I feel pretty comfortable about that. And the PD-L1 stain in this area anyway shows negative tumor staining, but lots of lymphocyte staining. So even if I'm not sure, it's really impossible to count how many are positive, but one can do their best with a sort of an estimate and get to a score in terms of a cutoff of greater or less than 1. Couple more examples I want to show. This is a biopsy, which is a real life biopsy with the usual. Sometimes we get folds in the slide, etc., in the section. There's a lot of in situ dysplasia here. This is not cancer, that's dysplasia. This is cancer. There is some cancer here. This probably is cancer, these 3 glands. Then there's some in situ. So when you pivot to the PD-L1 stain, one has to be, it's challenging to count only what we think is invasive cancer, not dysplasia, and only the immune cells around the cancer, not the immune cells around the dysplasia. So these are just some of the challenges. In this example, these again are tumor cells, and there's some stroma around. This is the PD-L1 stain, and there is some positive staining, and this is cytoplasmic, not membranous. So if this is a tumor cell, it is not to be counted. Here's some membranous staining, probably a tumor cell. But there's some other staining that is cytoplasmic here and there, and I don't know what the cells are. I don't know. I can't tell morphologically, even going back and forth. Are those lymphocytes? These are actually smooth muscle cells with a faint stain. So it does get quite challenging. Finally, we're asked, this is a metastatic colon cancer to the liver, just the concept of how much material there can be. This is only about 1/5 of the tumor on the slide. And here we're counting just percent tumor and percent immune cells. And I'm making a very specific point on this slide. There's almost no tumor cell staining here, but you can see some faint brown, even at this magnification, surrounding some of the cancer, and these are immune cells, and a lot of these are lymphocytes, others are neutrophils. And this is the PD-L1 stain. This is a vessel that's staining, and there is some cytoplasmic staining, a variety of things. Not sure what all these cells are, but we would do our best. But the other point about this is that when we're giving a PD-L1 CPS score, we just have to guesstimate the number of positive tumor and the number of positive immune cells. We don't have to give the denominator of what is the total immune cell count. And you can imagine how challenging it would be for us to try to count the immune cells in any section, let alone a large section. So percent immune cell is really quite challenging to feel good about. So in summary, I think I'm being the bearer of not very comforting news here. This is our reality, and every academic pathologist with whom I've ever spoken across numerous centers is in complete agreement with this, and we are really rattling the cage for something better. So in summary, the challenges with PD-L1 scoring are in the denominator, recognizing tumor cells from stroma, cautery and other artifacts, faint staining, and in the immune cells, it's really hard to distinguish the lymphs and macros from other cells and a variety of other things. The agreement at cutoffs is, I think, already can be quite challenging, but reproducibility for exact scores, should that be requested, I would expect that to be even less agreements. And I'm saying, well, I think it's an 8. Well, I think it's a 25, so I think that would be troublesome. And Jill mentioned something that I think there's basically no data on. What about the variability within the tumor, even in a single tumor, within biopsy fragments or within a resection? And what about, should we do a primary or a metastasis pre or post therapy? So those are really valid questions. Almost done. Just how to decipher a report. Okay, we're giving it our best shot. We do this test every day, and we will continue to do so as requested until something better comes along. But at Yale, in any case, our reports, I think, can probably be somewhat confusing, and I'm sorry if that's the case. We try to give for gastric and GEJ a score based upon the cutoff of 1 and say it's positive or negative. And what the equation consists of. In esophageal, the cutoff is 10, et cetera. It depends on the organ system. Elsewhere in the GI tract, when asked to do this, since there's no cutoff agreement, one just gives the percent of immune cells and percent of tumor cell staining, albeit despite the challenges that I've mentioned. And I just want to make a point here that while you can impute a tumor proportion score from this information, because the percent of tumor cells is TPS, that is what TPS is. But you can't impute a CPS should you want to from this, because the CPS is just the absolute number of positive immune cells. It has nothing to do with the denominator of the total number of immune cells staining at any intensity. So you can't add these together or in some way figure out. You're not getting the number of immune cells, which is what you need, the absolute number, which is what you need for a CPS. You're getting the percent of immune cell staining. Okay. Future directions, we would be thrilled to get as quickly as possible to automation with artificial intelligence and other software. And I think this is coming to remove the subjective interpretation from this process. I'm always comforted to hear from Jill that if one needs to treat a patient with a checkpoint inhibitor, it is possible to do so regardless of what the score is. But we still feel quite a burden that we may be giving a result that is not, could potentially not be accurate about a cutoff that you're counting on. And therefore the sort of the hope given to the patient about a response, we would like that to be real. But it does beg the question, are there situations where a PD-L1 stain, it may not be needed to treat? And if that's the case, it'd be great not to ask for it. Further, in addition to what I think, and I have to mention Dave Rim, always in a talk like this, for all the wonderful work that he and his lab have done. And he has a quantitative pathology laboratory at Yale that I hope will, I assume is working very hard on getting to automation. But in fact, there's other research, and Kurt Schalper in our department with Liping Chen, of course, they recently published in Cell in 2019. They're digging even deeper, because after all, there are those folks with checkpoint inhibitors who don't respond, and the group is getting into other discoveries of other potential important molecules, such as fibrinogen-like protein and its interaction with lymphocyte activation gene 3. So that's very exciting, and hopefully there'll be more things. I just wanted to share some references that I referred to in this talk, and thank you. I hope it's not too alarming, but it's a great opportunity for pathologists to share what's really going on behind that CPS score. Thank you.
Marie, that was awesome and maybe a little alarming.
I'm sorry.
Thank you for clarification. There was a question in the chat box, which I think you preemptively answered, about there must be scanning software and artificial intelligence that can do this. This just seems like such an onerous burden on you all. And at the end of the day, as you said, it's not really as quantitative as we all think it might be when we look at forest plots with cutoffs. So it looks like that is something that's in the works. And
I think people, I know people are working on this, and I agree with the person asking the question. There will be a better way.
All right, well, I will carry on, and thank you. That really lays the foundation for my talk. And now we're going to talk about how we use this information in making very important decisions for our patients. So hope you can all see my screen. I'm Jill Lacy. I'm a medical oncologist at the Yale School of Medicine and Smilow Cancer Center. I'm involved in caring for patients with gastrointestinal cancers and do have a strong interest in gastroesophageal cancers. So my topic tonight is it time for chemoimmunotherapy for all of our patients, or should we slow down and put the brakes on not so fast? And here are my conflicts. So I'm going to be focusing solely on first line treatment, not second line and beyond, and the role of immunotherapy in the first line treatment of metastatic gastroesophageal cancers. I'm going to review the data for chemoimmunotherapy. And when I say chemoimmunotherapy here, I'm talking about a standard chemotherapy doublet with or without an immune checkpoint inhibitor, and all the studies have been with PD-1 inhibitors to date. And I'm going to talk about the data in squamous cell carcinoma and the data in adenocarcinoma, which is different. Then I'm going to review some of the data for chemotherapy-free immunotherapy in the first line setting. We've heard a lot about the controversies surrounding PD-L1 as a predictive biomarker, so I will just highlight those, and then I will have some conclusions of my own and some of the questions and future directions that we are facing. So,
Did you click on your talk? There you go.
There we go. Okay, so immune checkpoint inhibitors, I think, as many know, in gastroesophageal cancers have really had a checkered history. They've had some pretty inconsistent and conflicting results, certainly in the second and third line setting and also in the first line setting. There are many reasons for this. This is really a heterogeneous group of tumors in every respect. We've just heard about the imperfections of PD-L1, and yet we continue to use it to design studies and to make treatment decisions. And then, of course, the trial designs, any trial design is never perfect. And I think there have been a lot of imperfections in the ways that the studies have been designed, in large part baked into the cake and for pragmatic reasons. But that said, I think in the first line setting, some consistent and reproducible data have emerged, especially in squamous cell carcinomas. As I said, I'm focusing on the first line setting. At present in the United States, we have FDA approvals for 2 IOs in the second line setting and beyond, both in squamous cell carcinomas of the esophagus. One with pembrolizumab, if the PD-L1 score is 10% or greater, that's CPS, and Nivo PD-L1 agnostic. So I'm going to talk now about the data in squamous cell carcinoma. So I just need to remind you as we go through this that when we talk about esophageal cancer, so often historically the studies have included both squamous cell and adenocarcinoma, so mixed histology studies really based on the anatomy. But in reality, these are very different diseases, many differences as are highlighted here, and actually not that many similarities, symptoms, overarching treatment algorithms, and prognosis. And I think what's really emerged is that, yes, these are very different diseases. This is from the tumor profiling and molecular analyses that we're seeing with esophageal squamous and adenocarcinoma. So the squamous subtype really resembles at a molecular level and a genomic profiling level, squamous cell carcinomas of other organ sites, whereas adenocarcinomas of the esophagus resemble the chromosomal instability subtype, and there are 4 subtypes of gastric cancer, the chromosomal instability subtype of gastric cancer. So really, there's no biologic or scientific rationale, I think at this point, in clinical trials for combining squamous and adeno esophageal cancers. It's maybe a pragmatic reason, but not really a biological reason. And I think that's important to keep in mind as we look at some of this data. So turning now to squamous cell carcinomas. This is remarkable. There have been in the last 2 years, 5 completed, published, large, randomized phase 3 trials of chemotherapy doublets versus a chemotherapy doublet plus a PD-1 inhibitor. And they are listed here. And these studies have all shown really a consistent improvement in overall survival with the addition of PD-1 inhibitor to chemotherapy. Remarkable consistency. And 2 of these studies have led to FDA approvals in the United States in squamous cell carcinoma. I'm going to focus in on Checkmate 648. This is the largest study by far, and this is the study that led to the FDA approval of Nivo with chemo in squamous cell carcinomas. I think you've seen the study design. This was a 3-arm study with chemotherapy, fluorouracil cisplatin as a control against chemo plus Nivo, and then a 3rd arm without chemo of Nivo plus Ipi. And the results are highlighted in this somewhat busy slide. So in terms of the overall survival, there was a benefit in both the PD-L1 TPS 1% or greater population, which was their first primary endpoint, about a 6-month improvement in survival, truly a stunning result with a hazard ratio of 0.54, and also improved progression-free survival and response rate. This is really dramatic data for this very difficult disease, and again, major advance in the field. Also, there was benefit in terms of survival for all randomized patients of about 2.5 months with a hazard ratio of 0.74. And of course, everyone is interested in the subset analyses that are often flawed, small numbers. But if you look at the subsets here, I think what jumps out is that almost all subsets benefited. Interestingly, females, and it's a small set, a number of patients in squamous, there did not appear to be a benefit. That's been seen in other studies. And importantly, that very important biomarker that we're all now relying on, PD-L1. And so that's blown up here on this slide. And so if you look at CPS first, the only group that did not appear to benefit in terms of hazard ratio less than 1 was a CPS less than 1. And that was only 9% of the patient. So all the others were, the hazard ratio was less than 1. If you look at TPS, this is interesting. In the group less than 1, there did not appear to be a benefit. And by TPS, less than 1, it's about half the patient. So the data is a little bit, I think, hard to wrap your head around. But in the CPS less than 1, there was a higher response rate. There was longer response duration, and it's possible that a survival benefit may emerge with longer follow-up. So in the other studies, just to run through, what these look like, 3 of them conducted in Asia, 3 global. These are all big studies. Keynote 590 stands out in that it was a mixed histology study of adeno and squamous, with 2/3 of them being squamous. Just different PD-1 inhibitors were used in each of these studies. Different chemotherapy backbones were used, although most were cisplatin based with either 5-FU or carbo or paclitaxel. Different PD-L1 cut points for primary analysis, different assays. But what's remarkable is the similarity in survival benefit in all of these studies of a couple of months with quite similar hazard ratios, with Jupiter 06 being most impressive. So this is a very consistent finding, and I think that really drives home the point of the value of PD-1 inhibitors in squamous cell cancers. And for those of you that like Kaplan-Meier plots, those are depicted graphically here for these studies. Now, how does PD-L1 fit into this? So again, we're getting conflicting results. I reviewed the PD-L1 story with 648, where it did appear that the benefit was greater with higher PD-L1 scores, especially TPS. We did not appear to see that same phenomenon in Jupiter 06 or in Orient 15, but there was an association with efficacy in PD-L1 and ESCORT, the ESCORT study. So again, not completely consistent, but overall, I think these are really impressive results. And again, if you look at the forest plots, and again, the big picture here is the hazard ratio is less than 1 in almost all of these studies in all PD-L1 subsets. So my takeaway message is that PD-1 inhibitors added to chemotherapy in this disease improves survival. And the magnitude of benefit has been similar across different studies with different PD-1 inhibitors and different chemo backbones. And the 648 study did lead to the FDA approval for Nivo, and that is a PD-L1 agnostic, so irrespective of PD-L1 expression. And we also have an approval from Keynote 590 for Pembro, also irrespective of PD-L1 expression in esophageal squamous as well as adeno. So I'm going to pivot now to adenocarcinoma. And here the story is a little less clear. The data is more conflicted. I would say that conclusions certainly can be made with caveats, but this is a little bit more of a challenging story, I think. So here we have 5 randomized phase 3 studies, all similar designs of chemotherapy doublets against chemotherapy plus PD-1 inhibitor. 2 of these studies, Keynote 62, which was using Pembro with chemo, and also had a chemo-free arm of Pembro alone. Traction 4 was a negative study, and then Checkmates 649, Keynote 590, and adenocarcinoma subset, and Orient 16 were all viewed as positive studies, and the two Checkmate 649 and 590 led to FDA approval in adenocarcinoma. I think in the aggregate, even though there's conflicting results here, there's a trend towards improved outcomes with the addition of PD-1 inhibitors to chemotherapy in the adenocarcinoma histology, as well as squamous. And again, I'm going to highlight Checkmate 649, because again, this led to an FDA approval. And you have seen the design of 648. This is very similar. Chemo as the control arm, chemo plus Nivo, and then a chemo-free arm of Nivo and Ipi, and here the Ipi dose is 3 mg per kg and Nivo 1. The chemotherapy-free arm was closed early due to futility, and they carried on with the other 2 arms. And then the key points in terms of results are shown here. The primary endpoint was in the CPS 5 or greater subset, and that was positive with a 3-month improvement in survival. And again, this is in this disease pretty impressive. We haven't seen this kind of result in decades, except in the HER2 positive group with a hazard ratio of 0.71. It was also a positive study in all randomized patients, about a 2-month improvement in survival with a hazard ratio of 0.8. So this was a positive study. Now, everybody is interested in the PD-L1 subsets, and is there benefit in PD-L1 negative and low? And that data is shown here. And so you can see that in the PD-L1 CPS less than 1, the hazard ratio is just under 1, but not impressive. And the same thing with less than 5. But if you look at responses, the response rates are higher in all PD-L1 subsets, including less than 1 and less than 5. So again, this study strongly suggests that there is a relationship between PD-L1 expression and efficacy from the addition of a PD-1 inhibitor. So again, here are the 5 studies, and in terms of how they look, in terms of geography, they were all large studies except the Keynote 590 adenocarcinoma subset. Most of them were focused on GEJ gastric, but Checkmate 649 fortunately included esophagus, and Keynote 590 excluded gastric. And they used, again, different chemo backbones and different PD-1 inhibitors. And for the positive studies, the hazard ratios in the overall patient population were quite similar, and hazard ratios not significant in Keynote 62 and Traction 4. And these are the Kaplan-Meier curves for the 2 negative studies. They really were negative studies. When you look at the hazard ratio, you ask the question, well, in the negative studies, did the PD-L1 high subset benefited? That did not seem to be the case. And in the other studies, we don't really have good data in the PDL negative or low subset. So it's hard to draw a lot of conclusions other than from Checkmate 649 about PDL quantification and benefit. Now, it's a different story in patients who are mismatch repair deficient or MSI high. And I think this is a really interesting and important story that deserves highlighting. So in both Keynote 62, which looked at Pembro chemo versus chemo, and Checkmate 649, Nivo chemo, they looked retrospectively at the small numbers of patients that were MSI high. These numbers are small, but look at these results. They're really dramatically favorable and dramatically similar with almost identical hazard ratios. And so I think there's no question that chemoimmunotherapy should be given to all patients without other contraindications who have mismatch repair deficient and MSI high tumors. This is a huge story. I think, in my opinion, New England Journal of Medicine worthy, but I think definitely worth highlighting. So can we explain the discrepancies in these studies? I would say I'm challenged to really rationally explain the discrepancies. We can talk about biology because gastroesophageal adenocarcinoma from a biological perspective is very heterogeneous. We've identified the 4 major molecular phenotypes, but that's just, I think, the tip of the iceberg. And we know, of course, that MSI high and EBV positives will be the ones likely to respond. A lot of challenges in the trial design, excluding esophageal adenocarcinoma or excluding gastric, different chemo backbones. And then, of course, the impact of post-study treatment. I think the explanation for the very negative ATTRACTION 4 study was that many of those patients did get PD-1 inhibitors in the 2nd and 3rd line and beyond. Now, how about HER2 positive gastroesophageal cancer? All those studies that we just reviewed excluded HER2 positive patients. So we now have pretty exciting data in this patient population with the inclusion of a PD-1 inhibitor with chemotherapy and trastuzumab. This is the Keynote 811 study, also got a lot of publicity, appropriately so. Simple design, trastuzumab chemo versus trastuzumab chemo and Pembro. And what we see here are the response data. And you can see very high response rate, very deep responses with Pembro added to chemo and Herceptin, higher response rate, and a complete response rate that's very impressive at 11% versus 3%. This study led to the provisional approval of Pembro added to trastuzumab and chemo in HER2 positive gastroesophageal adenocarcinomas. So obviously this is provisional. We are waiting for PFS data and overall survival data to see what the final impact is going to be. So we have 3 FDA approvals now in gastroesophageal adenocarcinomas. So Pembro from Keynote 590, which did not include gastric cancers, Nivo based on Checkmate 649, and Pembro added to trastuzumab chemo based on Keynote 811. All of these studies, all of these approvals by the FDA are PD-L1 agnostic, which is, I think, interesting and can be debated. So my takeaway message in the last few minutes is that adding a PD-1 inhibitor to chemotherapy in adenocarcinomas improves overall survival in most studies, but not all. That benefit has been seen with different PD-1 inhibitors, chemo doublets, and different PD-L1 cutoffs. I think we can conclude safely that efficacy diminishes with decreasing PD-L1 expression. And so how do we use this information? So I think that most patients with adenocarcinomas should be offered first-line chemoimmunotherapy. But I recognize that we are conflicted about what to do with patients who have no PD-L1 expression or low PD-L1 expression. So just for the last few minutes, I'm going to pivot to the data in gastroesophageal cancers for first-line immunotherapy without chemotherapy, so chemotherapy-free immunotherapy. And there are 3 randomized phase 3 trials that have addressed this question with a control arm of chemotherapy against an experimental arm of immunotherapy without chemotherapy. So we've heard about Checkmate 648 with squamous cell carcinoma that had the Ipi-Nivo chemo-free arm. We'll discuss in a minute, led to FDA approval just this past month for Ipi-Nivo in squamous cell carcinomas. For adenocarcinomas, we have Checkmate 62 which looked at chemo versus Pembro, and Checkmates 649, again, which looked at chemotherapy-free dual immunotherapy of Ipi-Nivo. These studies in adenocarcinoma were considered negative studies, and we do not have FDA approval. And then again, I'm going to highlight the data in MSI-high adenocarcinomas. So we've seen the Checkmate 648 and 649 designs very similar, except for the dosing of Ipi-Nivo, 3 mg per kg in adenocarcinoma, 1 mg per kg Ipi in squamous cell carcinomas. And side by side here are the Kaplan-Meier plots for overall survival and in their primary endpoint of PD-L1 positive tumors, and then down below all randomized patients. And so in adenocarcinomas, this was viewed as a negative study, median survival the same, although you can see the curves do separate at later time points, I think, which is interesting. The response rate was notably substantially lower with Ipi-Nivo. Different story in squamous cell carcinoma. This is a positive study with a significant improvement in overall survival in PD-L1 positive patients and also in all randomized patients. So no approval for Ipi-Nivo in adenocarcinoma, but it is approved in squamous cell carcinomas. Now, what are the red flags here for squamous cell carcinoma? So a big red flag is this crossing of the curves, survival curves, in the first 6 months, so a higher rate of death in patients getting immunotherapy alone versus chemotherapy. And we don't know the full explanation for that. We can come up with some plausible explanations, but we're not certain. I think we'll get more information from this study about that. If you compare immunotherapy alone versus chemoimmunotherapy in 648, which is not fair biostatistically, it does look like the survival curves are similar. But the duration of response in the responders does appear to be longer with dual immunotherapy versus chemoimmunotherapy. When you look at immunotherapy versus chemo, you have the very predictable expected differences in treatment-related AEs, but there were fewer treatment-related AEs leading to treatment discontinuation with dual immunotherapy. So this is really exciting. This has led to the first FDA approval of chemotherapy-free treatment for squamous cell of the esophagus. And for those that like the forest plots, here we go. Most subsets benefited, but again, in the TPS less than 1, the hazard ratio was 0.96. Now, in adenocarcinomas, we have another study, and this did not lead to FDA approval. That was Pembro versus chemo. Pembro was non-inferior to chemo, but again, you see those troubling survival curves crossing, so with a higher rate of death early on. And so right now, there's no approval for immunotherapy alone in adenocarcinomas. We have to talk about the MSI high patients, though, with adenocarcinomas. And again, we have Keynote 62, where they went back and looked at this, and Checkmate 649. Again, small numbers, but really impressive survival curves. And very similar outcomes with really virtually identical hazard ratios. Again, I think this is a huge story. And so it begs the question, should we consider immunotherapy alone as first-line treatment in patients with MSI-high gastroesophageal adenocarcinoma? So a story to be continued, and also I think, of course, begs the question, are we going to be curing these patients with MSI-high gastroesophageal adenocarcinoma either with immunotherapy alone or chemoimmunotherapy? So to conclude, to the question, chemoimmunotherapy for all or not so fast? So I think here are the considerations. Squamous versus adeno, it matters. PD-L1 matters, I think, especially in adenocarcinoma, but as we heard so brilliantly from Marie, it is such an imperfect biomarker. Is it good enough to guide us to select patients in whom we will not give immunotherapy? This is a really troubling question for us as clinicians. In terms of anatomic site for adenocarcinomas, I don't think we have any data yet that esophagus versus GE junction versus gastric is the issue. I think MSI, mismatch repair deficiency, trumps PD-L1, all those patients should get chemoimmunotherapy. And similarly for HER2, regardless of PD-L1, those patients now, inclusion of Pembro I think is reasonable. We're waiting for survival data. So here are my conclusions. So for esophageal squamous, I am offering chemoimmunotherapy to most of my patients, irrespective of PD-L1. And for the adenocarcinomas, I am taking a similar approach, but I am very circumspect about what we may be, how much we're helping patients if the PD-L1 score is 0 or very low. So again, the question, should we use PD-L1 scores to exclude patients from frontline PD-1 inhibitors? If we do, I think it has to be with circumspection and caution. I think particularly, after the information that we heard from Marie about some of the challenges with this biomarker. Chemotherapy-free immunotherapy, for whom and in what setting? So this is very exciting. It is approved ipi/nivo in squamous cell carcinoma, irrespective of PD-1. But again, that cautionary note, we are seeing increased deaths compared to chemo in the first 6 months. So that gives one pause. And so I think careful patient selection is the key, but I don't think we know yet how to select patients. Is it PD-1 or PD-L1 score? Is it the tumor burden? So, again, I think to be continued, this is an interesting story. And then for gastric adenocarcinomas, we're not there yet for immunotherapy alone as the initial treatment. I think even in MSI high patients, I think it still would be chemoimmunotherapy. So where we go from here, I think the questions are obvious. I think adenocarcinoma, we do need more, better data. We have the Keynote 859, another large randomized phase 3 trial of chemo versus chemo plus pembro. We're going to learn a lot from that study. It's a huge study. Clearly, as Marie articulated, we do need a better biomarker, period, full stop, writ large. And now the next phase. This is a big advance forward for us. I mean, really huge when you look at the history of the treatment of metastatic and advanced gastroesophageal cancers. So now we want more. So we need more effective immunotherapy agents or immunotherapy combinations. And now we're going to be moving into the realm of adding immunotherapy to other targeted therapies. So some studies that were planned or underway have now had to be redesigned in light of this data, adding immunotherapy to a targeted therapy and chemotherapy. And I've highlighted 2 studies, such studies that will be open here at Smilo Cancer Center shortly. And of course, now the widespread use of PD-1 inhibitors in the first line setting really changes the landscape in the second line setting and beyond in terms of how we design those studies and how we're going to be treating those patients. So much work to be done, but this is an incredibly exciting era for those of us who treat these diseases. And thank you for your attention. And I'm happy to take any questions in the chat box, but I know we are over time. So I'm happy to take questions by email. I know Dan shared his. Mine is the typical Yale email, jill.lacy@yale.edu.
Jill, I will ask a question to close. Thank you so much for that really sort of exhaustive and deep dive into the differences between squamous and esophageal. And it's so interesting to see about the PD-L1 scores and where they are making sense and where they might not be making sense. Are you ever in a situation where, despite that it's sort of the de rigueur to order the PD-L1 stain, that you might say, I'm going to proceed without it. I'm going to do for X, Y, or Z reason. Is that ever a part of the conversation at this point?
Yeah, so you're getting at the heart of what we struggle with in the clinic. My bias is to include immunotherapy, as I concluded in the slides, for most patients with gastroesophageal cancers with metastatic disease. Not that I know that it's benefiting everybody, because I certainly know that it is absolutely not, but I just don't have confidence that we are able to sort out those patients that are getting no benefit. So this is not like a KRAS mutation in colorectal cancer that's very black and white and very clear. There's not benefit to adding cetuximab or panitumumab. This is much more ambiguous and nuanced. So I think we're just not there yet. I do know that key opinion leaders, will agree to disagree about this point. And I know that people have different approaches to how to use immunotherapy in this patient population. We're all, I would say we're all struggling. And so I think at this point, it's just keep at it, more studies, more data, looking for better biomarkers.
I think that's useful for us to know as pathologists because of because of our struggles with interpreting that stain. Eventually, if it's not needed, that'll be great.
I can't speak for all oncologists, obviously. I do know that some oncologists, if the PD-L1s, if there is no PD-L1 anywhere, it's just flat out no PD-L1, are not including immunotherapy because there are toxicities. The treatment discontinuation rate was higher in all these studies in the immunotherapy arm, and that makes sense because you're adding in a whole nother class of toxicities that may lead to treatment discontinuation. And of course, we're all now experiencing that. We start chemo-immuno and have a treatment-related immune adverse event and are withdrawing the drug. It's also a cost issue, but I think I think that's a health economics issue for individual decision-making for patients, unless it's personal financial toxicity. I think it's a little hard for me to argue, well, it's costly to our healthcare system, so I'm going to withhold immunotherapy. If it's personal financial toxicity, that's of course a different story. So that's kind of how I think about it. But everybody, I think, looks at this differently. And right now, I don't think anyone has the right answer, or there's a truly a wrong answer.
Well, you touched on something that we can do, and that is the completely negative stain. We can agree on that.
and definitely, I know there are oncologists and some of our key opinion leaders in the field who feel we should. That's a setting where very comfortable withholding immunotherapy. You
can rely on our result, is what I meant. That we can read reliably. We can agree this is negative.
So that is important to know, actually. All right, we are beyond the hour. Thanks everyone who stayed to the end for your attention. And again, I think we're all happy to take questions via email. And have a good evening.
Thank you very much, everyone. Thank you, Jill.